Welcome everyone to the SAB's January educational webinar event, Comparison and Evolution of Peripheral Navigation Platforms with Dr. Ganesh Krishna. Before we begin the webinar, there are a few items to go over for everyone. You have all joined in a listen-only mode. You may ask questions throughout the lecture by using the question and chat feature on your control panel. We will address all the questions at the end of the webinar. Dr. Bawadam is the Education and Program Committee here at the SAB, and he will be moderating tonight's session. And I'll hand it over to him at this time to introduce our speaker.
Good evening, everybody. My name is Hasnain Bawadam, and I'm a board member for the Education Committee for the Society of Advanced Bronchoscopy. It's an honor for me this evening to introduce someone who does not need much of an introduction. I present my mentor, my guide, my teacher from University of California, San Francisco, and the IP program director, Dr. Ganesh Krishna. Dr. Krishna is not just an excellent teacher, but also a great scientist and a visionary who believed in the interventional nuances and the growth potential in its very primitive years, and underwent formal training in Germany from the infamous Dr. Jürgen Hetzel, when IP fellowships did not even exist. Dr. Krishna has not only been involved with the development of some of these navigation platforms, but understands the science, the technicalities, and the mechanics behind each of these platforms and how they can be used to continue the ongoing innovation and best serve our patients. So without much delay, I hand over to Dr. Krishna, who has an excellent talk prepared. Dr. Krishna, here you go.
Thanks, Hasnain, for the kind and ego-boosting introduction there. So my name is Ganesh Krishna. I'm a program director for the Interventional Pulmonary Program at the University of California, San Francisco. I'm based at the Palo Alto Medical Foundation, and my workshop is at El Camino Hospital. I just wanted to get the disclosures out of the way. I have I am serving as consultant for the entities that are described there. So this talk is going to be a little bit different from other peripheral navigation talks that you may have heard. This talk is primarily focused on upcoming advanced bronchoscopists and interventional pulmonologists, the younger generation, and the focus is going to be technical in terms of describing the peripheral navigation platforms that we have. How did they evolve? What are the basic principles of peripheral navigation? And rather than discussing what technology is better than the other, we are going to focus on how these technologies evolved and how the later technologies stood on the shoulders of earlier technologies so that peripheral navigation access has improved. We're going to discuss the important differences, the applications, the stepwise evolution of these navigation platforms, but still, what are the persistent problems that we need to solve, and an overview of the justification of secondary confirmation systems, including those that are from within and that are used from outside of the thorax. We make some comparisons of certain technologies and which direction they are going. And my primary focus is that most of us in the field of advanced bronchoscopy and interventional pulmonology are very good at validating the technologies that come our way. There is very limited participation or initiation in terms of innovation. We have a different focus in our training program, that we not only train our trainees to be excellent interventional pulmonologists, we have a strong slant towards innovation. And one of my goals is to talk to the younger generation advanced bronchoscopists and interventional pulmonologists who are in the audience today, to provoke your thoughts and to foster innovation. And for those of you who are going to hang around until the end, I have a video presentation of how our program supports innovation. This slide is worth talking about time and time again. For most of you are advanced bronchoscopists and interventional pulmonologists. You are very familiar with this, and this is a day-to-day issue that you deal with when you do advanced procedures. How do we access the various portions of the lung? We know that there are 17 to 25 generations of airways from the trachea until it reaches the respiratory bronchioles. And the trachea is about 20 to 25 millimeters in an average adult, with males having slightly larger caliber than that of women. It's about 10 to 11 centimeters long. And the mainstem airways are about 12 to 16 millimeters, again, larger in males. Segmental airways about 5 to 8 millimeters. And there is a geometric decrease in the size, not a linear increase, a linear decrease in size as we reach the periphery, because of the number of generations that it takes to get to the respiratory bronchioles and alveolar sacs is lower in the upper lung fields than that of the lower lung fields, just given the shape of the organ that we operate on. The therapeutic scope conventionally is about 5.8 millimeters, the working channel of 2.8 millimeters, and diagnostic scope was 5.2 millimeters, the working channel of 2.6 and 2 millimeters. But now we have working channels from 2.2 to 3.0, and smaller scopes and larger scopes are available. We use the different tools to perform different procedures depending on what we have to pass through the working channel and how much visibility and maneuverability we need. So I'm going to spend a little bit of time on the SuperDimension electromagnetic navigation platform, which for a very long time has been a gold standard for peripheral navigation. Now, when I said that I had, I'm going to be focusing on the technical aspects of peripheral navigation, it would be like almost the engineering standpoint of a medical professional. And why am I qualified to give you this talk? I've been involved in peripheral navigation for a long time. I did my first SuperDimension procedure at the end of 2004, beginning of 2005. And I've done over 1,500 procedures in SuperDimension. I have been involved in the development of the majority of the peripheral navigation platforms, and I've pretty much operated on all of them, either in the lab setting or on patients or both. And I've spent considerable amount of time, taken a lot of effort in learning about the technical aspects of each of these systems, and I'm able to provide a reasonable comparison of those systems. I think it's vital for us to understand the technicalities of the system that we operate on so that we can be not only better proceduralists, but innovators. So again, the SuperDimension electromagnetism-based navigation platform is largely the gold standard for that technology. It takes you from point A to point B, like a navigation platform. If to provide you with an analogy of the GPS system, if the three sensors that are placed in a triangulated format on the chest wall are the satellites, if the tracheobronchial tree is a road, the locatable guide at the tip of an extended working channel is the car, and the driver being the bronchoscopist, and the electromagnetic generating field generator at the bottom of the patient under the thorax is the globe. That it basically is how the SuperDimension system works. So the important aspects of this technology is that it needs a sensing volume that is generated by a field generator underneath the patient's thorax, and a single point on the tip of the locatable guide is sensed at 6 different axes, namely X, Y, Z, roll, pitch, and yaw. And the feedback is given to the computer about 170 times a second, and that constitutes a real-time localization of the tip of the locatable guide within that sensing volume created by the electromagnetic field. For those of you not familiar with the roll, pitch, and yaw, the cartoon of the airplane. It tells you that the longitudinal axis of the airplane is the roll. And if you imagine a rudder in front of the plane on its nose with the vertical and horizontal plane, the pitch and yaw are the rotational axis of those two. The electromagnetism that is generated by the field generator is about 45,000 Teslas, less than that of a standard MRI. And so it doesn't cause a whole lot of interference like the conventional MRI to metal, but there is some interference, and that has to be taken into account. And canceling technologies using a phantom are in existence. And that's basically what the company representatives will do. The engineers will come and create have a phantom and set up the room for the system to be used. We are going to go through the evolution of the super dimension system. Initially, when we started using, as I showed you in the previous slide here, the yellow catheter, most of you may not have even seen this. We did the manual registration and we calculated the CT to body divergence, which was given to us as a number. And we used the yellow dial where we there is an arrow on top. I don't know how many people can see that. You can rotate that arrow to the direction you want to flex the catheter, and then by pushing the piston on the back end, we navigated through the periphery, which was a lot of fun to do, but it's quite labor intensive. And the catheter initially was straight, and subsequently they came up with this edge catheter, which is borrowed a little bit from the cardiologists, and they did angiograms. And that helped us navigate through the maze of airways that we had to do with flexion extension and the natural curvature, which came in three different extended working channel with the 118, 90, 45. And initially they had a straight one too, which kind of dropped out of the scene as it was not used much. Further augmentation of the software, I'm just pointing out the most important ones in terms of software upgrades. The 6-panel view kind of helped us a lot in furthering this technology to reach the periphery. In the right panel, you will see the MIP, or maximum intensity projection view, and the bottom is the local view, which is a sliced view of the CT scanner in front of it. And you can see that the green ball, which is the center of the target based on the planning, it has this sunrise sign, so to speak, that you can see on the panel, that the locatable guide, which basically is going through the extended working channel through which the biopsy tools also go, is in the same plane as the target that is intended to be biopsied. And the local view gives you a single planar view, which actually helps us determine the appropriate location for biopsying. So this was a good addition to the software upgrade, which helped us further this technology to access peripheral nodules. Now, there's a lot of debate as to what tools to use in what order, and it's a worthy debate, and many people have developed their own practice patterns. I have my own, which I will elaborate, but this is kind of the list of things that we have at our disposal. The bevel needle, there are multiple types of needle, including the super dimension arc point. The ion system has its own needle. The needles are a little bit longer now. Different gauge needles have been used, all the way from 19 gauge to 25 gauge, 21, 22 being the most commonly used needle. This triple brush, which we call the violator, which kind of randomly goes into different directions and collects cells. If you're not sure where you are, it's sometimes people kind of jab that and hope that we collect some cells. There is cyto brush, which is in the bottom panel, and there is a needle brush, which because the inherent nature of the procedure that travels through the airway, we have to do trans-airway aspirations and tissue collection or cell collection. So the needle brush was in use, widely used for a while, and some people still use it. Of course, forceps are a big part of this. There are different types of forceps. Basically, we not only need cells for cytology, but also tissue for pathology in order to make diagnosis of non-small cell lung cancers and the subtyping and molecular and genomic and immunologic profiles of the tumor cells. So the forceps is a useful tool, and now we have flexible cryoprobes that we use through the robotic and other platforms to get better tissue acquisition. And there are recent publications on the efficacy of those tools as well. The GenCut, which is another device that works like a deli slicer, biopsy from the side, and sucks tissue in and is useful in certain circumstances. It's worthy of mentioning here at this point is the cross country, which we will talk a little bit more when we talk about the Bronchos technology, but it was a trans-airway introduction of the external working channel with the Seldinger technique with the needle and then sheath covered over in the hope of collecting better tissue has been utilized. I have done this and will no longer do this, but these are all steps that we took in the past to get to where we are today. I will show you my paper that we published a while back. So these are procedures that were done with that yellow push-pull catheters in 2005, 6, thereabouts. As you can see there, if you take the time to read the paper, you see that the size of the nodule that we approached was about, average of 3 centimeters. So it's a mass. So, I want to emphasize that these are like early procedures, and we didn't have anything other than conventional bronchoscopy. So this peripheral navigation was a big step forward for us. But given the deficiencies of the system and operating in an organ that is constantly moving with influence from transmitted pulsations from the great vessels of the chest as well as the heart, it took a while for us to master this technique and slowly improve our diagnostic yield, not only in terms of establishing the diagnosis, but also to access smaller nodules. So our average size there was 3 centimeters. We did demonstrate a diagnostic yield of 89%, and we also presented data on 2-year follow-up of all these patients. It is, for those of you who are looking at the title of this also, will understand that originally when we started doing this procedure, we did this under moderate sedation. I quickly learned that was not going to be successful. So these cases were done with propofol sedation, and the purpose of this paper was that propofol sedation and deep sedation in general increases the accuracy of electromagnetic navigation. I did these cases without an anesthesiologist present. I intubated the patient myself with a nurse practitioner administering propofol, and we actually did the procedure and recovered the patient ourselves. So this was a NAPS protocol, nurse-administered, physician-supervised anesthetic procedure. A couple of clinical data worth mentioning on electromagnetic navigation with their drawbacks and positive aspects. Navigate study, which was published in 2017. I was an investigator in the study. Looked at 1,000 patients, and only half had the bronchus sign, which I think is kind of falling out of favor. We no longer need a bronchus sign to decide whether we should biopsy someone or not. We had a diagnostic accuracy of about 87% was reported. And the follow-up was for a very short period of time. A month follow-up is insufficient for most of the nodules that were non-diagnostic. Other drawbacks of the study was an industry-sponsored study, and it is a late post-market study. The technology has been around for almost a decade before this study came out or more. And people already had established beliefs about whether the system works or not. So this study, I doubt changed anyone's mind regarding the utility or lack thereof of the system. The acquired registry is another interesting study. It's in an ideal world, it's a well-conducted study, but as it pertains to looking at peripheral navigation platforms, there are significant deficiencies here. If you look at the average number of procedures that an operator did for this technology over 4 years, is about 11 cases. And we all know that the more you do, the better you get. And someone who's doing 11 cases every 4 years doesn't seem like someone who will be able to give us reliable data on whether the system works or not. So that's it. Moving on to other technologies that evolved from the platform that was set by Superdimension. People thought that the stability of an airway was better in the proximal airways, and the BTPNA stands for bronchus transparenchymal nodule access, and Bronchus Technologies came up with this platform where they thought that the proximal airway, if we tunnel from the proximal airway into the distal, create a straight line towards the nodule and put in a sheath and access them, there is better column support and better access to the nodules. But things are far more complex than that. First of all, the tunneling mechanism from the proximal distal airway significantly distorted the anatomy, and access was not very good. And also, if you introduce a sheath and leave it there and get the benign diagnosis for the patient, that wasn't looked upon very well. There were very few cases that were done overall, and this technology fell off by the wayside fairly quickly. And like many other technologies, one of the drawbacks I would state for this technology is that there wasn't enough trials that were done. Not enough good data was generated before it came to the market. There was like an abstract presentation, and then subsequently the system was marketed. You could see that the place where they would start the tunneling, although seems like a stable place, it also is worth noting that those places would be the vasculature that would be proximal to those places would be fairly large, and damage to those vessels would lead to significant complications. And the CT to body divergence and the airway to nodule relationship that are altered by instrumentation in the airway, which we will talk about a little bit more, plays a substantial role in how the access to the nodule is done precisely. And this did not solve that problem, and in many cases augmented the problem. And again, I showed you some slides on the cross country by Medtronic, which was a similar platform that Medtronic came up with Superdimension, but going a little bit more distal into when the tunneling happens, but that didn't fly very far either. So this again, as you can see, there was an abstract that was presented for the feasibility of the bronchus transparenchymal needle aspiration. There's not a whole lot of large studies that was conducted on that, and the technology fell by the wayside fairly quickly. Now moving on to a modified version of the electromagnetism-based platform, Varan came up with this idea, from which we learned quite a bit. The system used a hemithoracic volume assessment, which means that the sensing volume was used only on one side of the thorax. They had a central sensor and a lateral sensor on the ipsilateral side of the nodule that was going to be accessed. And this is the first, this is a system that seemed to have some recognition for the CT to body divergence, and some corrective measures were taken. in the form of respiratory gating. They did the inspiratory, end inspiratory, and end expiratory scan, and they looked at thoracic volume changes, and they tried to adjust for that, and the CT being done on the same day with respiratory gating to offset the CT to body divergence that happens from the time of the CT scan imaging that was done on the patient to the time that they are subject to an anesthetic and the procedure performed. One of the other, it is similar to superdimension in the sense that it is also a tip tracking system. So only the tip of the catheter was tracked, and they also had a disposable bronchoscope that had the sensor at the tip, which was somewhat problematic, as when we did the biopsies, oftentimes you had to re-navigate to the location, which was somewhat of a problem. And they added the virtual image guided transcutaneous option, as the navigation platform was not as successful as they had hoped to be. But that was not a very fair comparison to a image guided biopsy done by the interventional radiologist, as again this transcutaneous spin perk is a virtual guided transcutaneous biopsy, whereas the IR guided biopsy was real-time imaging. So that did not compete as well as one had hoped. But the interesting thing is that we learned a lot about CT to body divergence by this hemithoracic volume assessment. We learned that changes happening on one side of the thorax affects the other side, and therefore having a hemithoracic volume assessment is not exactly the best way to go in a sensing volume-based, electromagnetism-based platform. And also, we know that tip tracking can only, within the sensing volume, is only a single point tracking, which can also be problematic, which subsequently improved in other systems that came on later. So before we talk about augmented fluoroscopy and fluoro-based navigation augmentation, is some things to talk about, which is a difference between a pixel and a voxel. A voxel density is a data point in a three-dimensional space. It's volume pixel, whereas pixel is a data point on a single 2D plane, and each pixel is recognized in comparison to the adjacent pixel. So there is individual coordinates for each pixel point on a 2D plane, whereas volume pixel is a three-dimensional plane, and each data point is recognized in relationship to the adjacent point and not as individual coordinates. And the voxel densities, for those of you who do lung volume reduction, know that that's basically how the tissue destruction score is calculated in Hounsfield units. When you do the lung volume reduction for COPD, and that voxel density is ideal for an organ like lung because of the heterogeneity of the tissue that we see, and that actually played a role in the fluoro navigation platforms and body vision and so on and so forth, which we'll talk subsequently. Just as a reference point, air is minus 1,000, water is 0, and bone is 3095 voxel density or Hounsfield unit. So before we go on, I wanted to point out some of the experiments that I did around 2009, 2010 thereabouts. This is primarily to again talk to the younger members of our field in the audience as to how the systems evolved, and there are things out there that still need further exploration. We had an NIH grant with which we worked on in collaboration with one of the radiology professors at Stanford, Dr. Farig. This is called a scanning digital beam X-ray, which actually is an inverse geometry in the sense that the source and the detector are inverse, and the the electron beam is scanned over a very thin anode, and the system the detector is a fast picking detector. It's made of cadmium telluride, and it's able to pick up multiple photon beams at multiple angles, thousands of them in seconds, and able to create a tomo view. It had a lot of applications in the cardiac field, and we did some experiments, and we had 3 publications on this in medical physics to see how we can track the nodules with the super dimension. These are the other 2 papers published in 2013 and 16. The previous paper that I showed you was also in medical physics in 2012. You can see the tomosynthetic view on the left-hand panel. We created a nodule or lesion that has similar density with a mix of Vaseline and petrolatum jelly, and it created about 100 Hounsfield units, which is similar to a solid nodule. And we know that the locatable guide is about 5 millimeters outside of the external working channel in the super dimension system. And we placed fiducial after we reached that particular distance, and we marked that, and then we placed the fiducial and scanned it, and then compared that distance in multiple targets. We demonstrated that this tomosynthetic view is able to clearly show us the nodules of that density, and we were able to acquire the target better by using this system. The significant drawbacks that we encountered in the system was that the source to detector distance had to be 90 to 100 centimeters, which is not always good. The shorter the distance, the better TOMA angle we got. And also there was significant electromagnetism interference between the 2 systems, such that we had to move the C-arm out of the way when we navigated, and then brought it in and to do it to get better accuracy. These things did not play very well in terms of the logistics, but I think it is an early effort to look at extraneous systems for using fluoroscopy. It's important to note that the radiation dose of the system is about 2 to 10 times lower than a standard fluoroscopy, depending on how much pixel or PPS that we use. It was a significantly low radiation dose. This technology still exists, and probably in non-electromagnetism based platform, it may have a more viable option as a secondary confirmation tool, and that remains to be seen. So moving on to how these systems further impacted it, it's interesting to note from my standpoint that these postdocs at Stanford that I worked with on the triple ring, the system, the inverse geometry that I showed, subsequently also worked for the various companies developing these systems, and I had worked with them again. So you can see that the same people who were postdocs and PhDs at the time subsequently moved to these companies and were involved in the development of systems that we now use. Speaking of which, the fluoro-based systems or C-arm-based tomosynthetic view has caught on as a inbuilt secondary confirmation systems in some of the systems that we use now. I will play this video of the CABT that is used in the fluoro navigation platform. It uses a 50-degree sweep with fiducials placed underneath the patients on the electromagnetic board, and the tomosynthetic view is obtained by making that arc. Each of these, and the voxel density of the target is picked up and projected in multiple planar views. And the 3 reference points that are used to locate the target would be the tip of the LG, and the airway, the conduit airway that takes you to the lesion, as well as the lesion itself as it is visible. Now, again, that the drawback in that system is that both the LG tip and the lesion are marked by the operator by making adjustments in the view, and you just saw in the video that you have to alternate between the standard fluoro view and the tomosynthetic view, and it's not always easy to actually mark it in the exact location. So that was one of the drawbacks, but it certainly helped us understand, and the system allows you to target either the augmented view target or the conventional navigation target, so that gave us options. Unfortunately, there is not enough data that was collected in a properly conducted clinical study to demonstrate the effort. I've done multiple cases with FluoroNav. I think it's a valuable addition to the superdimension technology, but validation studies have not been forthcoming. The other fluoro-based navigation platform that is worth discussing is Lung Vision. It was originally developed as a standalone technology. However, it actually now is used as a secondary tool in multiple peripheral navigation platforms. And Nova Ray is the newest one that is, again, heavily dependent on this augmented fluoroscopy for peripheral lung access. The salient differences between body vision and fluoro navigation is that there's a 60-degree arc, and the computer generates the reference points. There's 5 reference points in the ipsilateral lobe where the lesion is by selecting 5 different airways, and we would pass the catheter all the way to the periphery, and that is recognized within the recommended pathway by the computerized algorithm. And then this sweep of a 60-degree arc uses that tomo view to locate the target in relationship to those 5 airways that was previously picked up by the computer. Conceptually, it's actually a very viable and very sound concept. And again, there were limited number of studies that were done. To the best of my knowledge, a good study has not been published on this, and the system now is being used in conjunction with other peripheral navigation platforms. If it came out as a standalone technology, one of the biggest advantage would have been that it was very cost-effective and economic. These videos, again, show you the tomosynthetic view of the body vision. You can see the fiducial markers underneath. And then this is a overlap, which, again, has subsequently been also used by some of the cone beam CT, especially the Philips Lung Suite with the fluoro overlay. And the tool that we are using here is the GenCut. So it's important to point out that, the GenCut actually biopsies from the side, and that's why it looks like the tool is actually going beyond the intended target. And here's another tomo verification. As you can see that the density changes as you look at the different images in the 60-degree arc, and you can actually see that the lesion is accurately reached with the biopsy tool. Furthering the evolution of peripheral navigation, one of the significant drawbacks of superdimension for those of us who have used it is that the locatable guide protrudes about 5 millimeters outside of the external working channel. And that is problematic because the needle that we use is about 8 millimeters long. And when you change a 5 millimeter distance, when you acquire the target, that can be an issue for reaching the center of the target. So the modification that was made was to transfer the coil, the sensor in the locatable guide to the external working channel. So you have these double sensor, one at the tip of the locatable guide and the other one at the tip of the external working channel. And when you pull out the locatable guide, you still have alignment. Conceptually, again, it makes sense, but the problem is that those 5 millimeter adjustments still have to be made. and the way the sensor was hooked up to the tip of the external working channel has to come through the entire external working channel through the place where we tighten the external working channel at the proximal end. And if you tighten it too much, it actually breaks the connector, and the sensory input that you get from the coil is lost. Or if you do not tighten it too much, or do not tighten it to the extent that it doesn't move, then the catheter itself moves with every back and forth stroke of the biopsy, and that can be problematic. In my opinion, the Lumicide was not the best advancement that SupraMention made, but there was the significant forward motion with the edge catheter and the fluoronav and the 6-panel view were all good advancement. This one didn't meet all the expectations as one had hoped, in my opinion. So with all these changes and improvements in software and other newer technologies, the main problems that we still face in peripheral navigation is twofold. One is CT to body divergence, which is basically something that happens in the lower lung zones more than the upper lung zones. It is the left cartoon that shows that. Many studies have shown that CT to body divergence can be up to 12 centimeters. And it's the difference in the thoracic volume from the time that the image is acquired to the time that we do the procedure. And then the second, somewhat less recognized problem is the airway to nodule relationship, which happens more in the upper lung zones. And it's due to instrumentation of the airway. And the airway is a pliable organ, and the catheter that we use is relatively stiff. So it does change the position of the nodule in relationship to the target. And factors that determine the extent of the change are the size of the nodule. The smaller the nodule that we desire to access, the more we should pay attention to the airway to nodule relationship. The distance of the target from the conduit airway. If the nodule is farther away from the conduit airway, the nodule moves independently of the conduit airway. If the nodule is practically attached to the conduit airway, it moves with it. So that will play a role. And the extent of catheter stress that we have also plays a role. And in the bottom panel, you can see the ion robotic bronchoscopy catheter going through the airway without causing much distortion. We get more into the detail of that into a small nodule in the left upper lobe. And a conventional bronchoscope distorting the mediastinum sinum by pushing the tracheal wall to the contralateral side, exerting some downward pressure on the left mainstem bronchus and making that turn. This, again, as I said before, becomes a bigger problem in sensing volume-based platforms where anything that happens in the lung affects the airway to nodule relationship. Again, these things don't matter if you're going after a 3-centimeter mass, and it matters a lot if you're going towards a 8 or 10 millimeter nodule. So I briefly mentioned this anesthesia criteria, which we will discuss more as we go along this talk towards the end when we discuss various robotic platforms. We, in the robotic bronchoscopy, use a PEEP of 10, 8 ml per kilo ideal body weight tidal volume, and a complete neuromuscular blockade. And we have demonstrated that it at least decreases the CT to body divergence. It may not affect the airway to nodule relationship that much, but there is ways to look at that and make adjustment in the procedure, and we will discuss that in a later slide. As it pertains to the ion, we always keep the endotracheal tube 5 rings above the main carina to maximize the shape sensing technology. Again, we'll discuss that more when we talk about the robotic platform. And we keep the lumen in the middle or towards the ipsilateral side of the target lesion to maximize the shape sensing technology. Again, we will talk about that as we go further. So these things may not apply to tip tracking technologies, and more so for the shape sensing technologies. So, people may talk about secondary confirmation system, what is best, should we use it from the outside or from the inside? But there is not a whole lot of debate as to whether or not we should use secondary confirmation technologies. The organ that we operate on is a complex one. It's constantly moving with respiration. There's great vessels in the heart, in the mediastinum, that are constantly pulsating and has transmitted pulsation. There are significant changes in the thoracic volume by extrapulmonary organs, such as the belly, body fat, and if there is more of the person around the lungs, that's going to have a significant impact on the thoracic volume. Using anesthetic, neuromuscular blockade, also changes thoracic volume. So there's so many factors. So I'm not sure that there is a way around, not using a secondary confirmation technology. Secondary confirmation technology, we'll discuss both. Those have been used from the outside and those that are used from the inside. Standard fluoroscopy is the most common one, which basically almost everybody uses that. It is a very useful tool. It'll tell you where your catheter is as we go to the periphery. It decreases, complications by stopping us from going too far. Less radiation, cheap to acquire. It's basically present in every hospital system there is, and it is easy to use, and most of us know how to use it. There are some, things that the fluoroscopy is beneficial, but also there are certain disadvantages. You get two-dimensional view, and most targets that we are going after is not visible by fluoroscopy, standard fluoroscopy. We can use, multiple features like edge enhance and things like that, but again, majority of them are not visible. Radiation exposure, of course, it has to be taken into consideration for any ionizing radiation that we use on our patients and for ourselves and the staff. Optimal angle is not easy to determine, and transverse views can be problematic, and because the arms get in the way. It does give us some benefit of knowing whether we are too close to the pleura, but it only works in the AP view. If the catheter is coming towards you or going away from you in the anteroposterior direction, we may not be able to assess that. And you can see in the view that the differences in the physical properties of the locatable guide in the superdimension tool, and when you take it out, the trajectory of the external working channel completely changes. And for us, when we monitor that, at least we may be able to make some adjustments with the biopsy tool when we know that there is a change. But there are changes, and you can see that the trajectory of the EWC is very different when you pull out the locatable guide at the same target, and the target acquisition, which may be precise with the locatable guide in, may not be as precise when you take it out. Another commonly used secondary confirmation system is the radial probe ultrasound. It has high resolution and the sub-millimeter resolution to look at the airway in multiple layers. There are several piezoelectric materials that are used. Lead ziconate tungstate and lead tungstate and quartz ceramic and bone are all piezoelectric materials. The most commonly used in our specialty is the silica or quartz, both in the linear and radial probe. The lower the frequency, the higher the penetration, but lower spatial resolution. For example, the cardiac echo is about 5 megahertz. Standard endobronchial linear ultrasound is about 7.5 to 10 megahertz is what we generally use, although there is a wider range that the system allows you to do. And radial probe ultrasound is about 20 megahertz. So the acoustic signals based on tissue impedance is converted into grayscale imaging, which is what we basically look at. So I'm going to move forward with this. There are significant advantages and disadvantages of using the radial probe ultrasound, which is the most commonly used ultrasound. We are not going to discuss linear ultrasound here in this talk. I've shown you a case that we did, bilateral lung nodules. They were both diagnosed as carcinoids. But the problem in the, there are different problems that we encounter in the outer third, middle third, or inner third of the lung, depending on the size of the volume. It's basically a 1.9 millimeter probe that goes through a working channel that is about 2.0 to 2.2 millimeters, in the airway that in the smallest airway in the lung is about 3 millimeters. So it is important to note that the image acquisition with the radial probe ultrasound completely depends on how well the tissue approximates to the probe, and that's not easy to acquire. And one of the things that I've noted in observing various people, when I go proctor, is that the training is very non-uniform. Not very many people know how to detect the ultrasound imaging. People, obviously, advanced bronchoscopists and interventional pulmonologists are well trained, but in the general population, image acquisition and understanding the nuances of the catheter diameter and the airway diameter unit, and the importance of having full approximation to get a useful image, that knowledge is largely lacking. Some of the things that are worth mentioning here, that those systems have fallen out of favor, but it's important for people to be aware of them because they have not vanished. They may have a comeback in the future. Confocal endomicroscopy is one of them. So the cartoon on the side will tell you that the laser beam is focused on a dichroic mirror, which then passes through a lens and reflected on the tissue. And the image that the light that comes through, the laser light that comes through the lens coming back from the tissue, is passed through a pore into a detector, and that's the reason why it's called confocal. Those wavelengths are converged through that pore and detected and converted into grayscale. So the important thing to note here is that the system depends on the light reflection from tissue. And in the lung, it has been shown that the interstitium reflects these lights. And I'll show you a case that we did. And again, my interpretation of this may be different from yours. So that basically became the essential problem. So as you can see, the alveolar sacs that went by, and now you have this hazy image. And I think those, in my opinion, are the abnormal areas, because this is a patient with a ground glass nodule. And my understanding of the ground glass nodule is the lipidic growth pattern, or the SNR growth pattern of cancer cells along the alveolar sacs, and they obliterate the reflection that is otherwise normally occurring in the alveolar septa. And you can see the alveolar sacs very clearly here. Don't think they are abnormal, but then when you see that haziness, that is because of those cells obliterating the reflection. And I went after those areas and did biopsies. And in some cases, I was able to prove that was adenocarcinoma. Again, the larger data was needed, and when a bunch of us met and discussed this, there was so much inter-observer variability. Other people thought that they were able to look at lymphocytes, and you are able to look at macrophages, but people were making diagnosis of rejection, of bronchiolitis, and so on and so forth, which was not always something that was universally accepted. And not enough experiments were done in vitro to look at those other cells that people claim that they have seen in the lung parenchyma. And it is not that difficult to do. You can isolate lymphocytes and other cells, and you will be able to look at it with the same system, which had two wavelengths that it was looking at. But unfortunately, that did not happen. The system still has applications in the GI tract to look at Barrett's esophagus, but the gastroenterologist used methylene blue as a contrast. And we were totally dependent on the natural reflection of light from the lung tissue, and there is limited use of this because of that. So coming to cone beam CT, which has gained a lot of traction along with augmented fluoroscopy in terms of picking up these images. So cone beam CT is a significant variation from traditional CT. The X-ray tube and the detector panel, they rotate around the patient, and sending out a cone-shaped ionizing radiation, which is absorbed by the tissue, and then the residue was collected by the receptor and converted into a grayscale algorithm with three-dimensional view with axial, coronal, and sagittal views. The conventional slicing CT has better resolution than cone beam CT, but the radiation dose is substantially reduced in the cone beam CT. We already talked about augmented fluoroscopy, but there are tomosynthetic algorithms now in augmented fluoroscopy that gives you a reasonable picture, compared to that of cone beam CT. Sometimes those images are comparable in a well manufactured devices. I'm not going to mention any names here, but there are some augmented fluoroscopy images that are comparable to cone beam CT images and much cheaper. A quick note on the ultrasound-based systems. This is coming into the market as we speak. A 30 megahertz peripheral probe at a 9-degree angle needle with a 25 gauge is something that can be used with a small bronchoscope, but still we need navigation platforms. So this system was largely built to coexist with another navigation platform compatible with the working channel, so you can go in and rather than just looking at it, the radial probe ultrasound, you have the opportunity to pass a needle at a 9-degree angle. One of the biggest problems that we have with the system is that the torque that you have at the proximal end is not one-to-one. So if you want to make adjustments for an eccentrically placed nodules, it's a random rotation, and that's not always going to be successful. The length that is needed to get into peripheral airways makes it very difficult to make a torque-based system. And again, with the needle coming out and the real estate that it takes to scope, also has problems in terms of approximation on the airway and changing the approximation to different walls, especially in the outer third of the lung. So those can be problematic. Lack of navigation, extra use of real estate in the tip of the catheter with the needle, so that the approximation can be an issue. Success in the middle and outer third is debatable. So this is a small study that discussed this. We're going to move on. So coming to the robotic assisted bronchoscopy systems, there are two systems that are currently available, which are significantly different from each other. It's worth noting the differences, the advantages and disadvantages. Direct endoluminal assessment has been touted as a useful mechanism for one of the robots, and you can see in this cartoon that we are able to move around. But again, this is possible at best in the middle third of the lung. This kind of visualization and approximation on different airways, either with the biopsy tool or the ultrasound to look where the nodule is just not possible in the outer third, especially given the outer diameter of 4.5 millimeters in this system. There is, a lot of interesting findings that we did by doing more and more of the Ion and Monarch robotic systems. The robotic system offers stability, which is very important because a handheld procedure, no matter how good you are, is going to be difficult with us breathing, talking, turning, shifting, and so on and so forth. The stability offered by the Monarch platform is different from that of the Ion. The Monarch has a mother-daughter concept with the proximal end about 6 millimeters and the distal end about 4.5 millimeters. So the column support provided by the proximal end to the distal end is actually the stability, but it's a static stability. The shape sensing technology in the Ion robot gives you a dynamic stability because the system constantly striving to maintain that position that you set in. We will talk about more in detail as we move along. So the Auris Monarch platform is largely modeled on the Varan platform. It uses a ipsilateral field generator, but not the field generator is on the side of the patient. It uses a tip tracking mechanism. There is no respiratory gating. The outer diameter of the distal catheter is about 4.5 millimeters. It has an irrigation system where you can pump in air or saline or water to distend the airway as you move forward, which may or may not be a good thing. You can clear out some blood, but it also the any liquid that you put in the distal airway can affect your view because the water sometimes serves as a lens and it distorts it. Multiple small water particles can be an interference in carefully assessing the luminal abnormalities that you might encounter. But also, we have noted over doing many cases that endoluminal component is not very common in peripheral lesions. So the virtual target volume was superimposed on a CT image, which is a software addition. I did the first human trial on the AURIS robotic system. As you can see, it was posted on April 13, 2018. And we did a few cases. The system, I was unable to successfully complete the study due to various issues, and therefore we terminated the study. Subsequently, multiple advances have been made in the software, and you can see that one of the things, this is again one of the examples that I wanted to quote as to how the later systems actually stood on the shoulder of previously existing systems and try to make it better for us as end users. And you can see that the same modified MIP platform with the volume differences in the target was able to be superimposed, and similarly the placement of the tomo view on the fluoroscopy now is being modified to place it on the CT scan as you navigate down, and you're able to simulate, at least virtually, the target as from a MIP planar view and help navigate towards the area that you want to navigate. So this is the first day that we did the case there. This is a team from the AURIS platform and my team, and my former fellow, who is IP fellow, who is part of this, Dr. Ihab Al-Shali, who is now in Cleveland Clinic, Florida. So moving on to the ION platform. So what is shape sensing technology? So this is the latest technology. So it's a non-electromagnetism based technology. One of the things that is important from a non-electromagnetism based technology that I wanted to emphasize is that something that uses a sensing volume, whether it is a full thoracic volume or hemithoracic volume, is more affected by changes in the thoracic volume, which basically is a problem for every single peripheral navigation platform. Now, this system does not require electromagnetism, and therefore it is more dependent on the airway anatomy, and distortion in the airway plays a bigger role in how this system is affected compared to that of any electromagnetism-based platform. So that by itself, so the distortion, the stretch, the pull, the twist of the airway is much less than that of the parenchyma, perhaps maybe a little bit exaggerated in the distal, maybe a third of the lung in the last segment where we try to do the biopsy. But in general, sensing volume-based systems are more susceptible to the distortion, and the target acquisition is affected more compared to a shape sensing technology that depends on airway anatomy more than anything else. So the basic functional unit of the ION robotic system is a fiber rag grating sensor, and we'll talk about more of what that is. And the sensors are along the catheter in its entire length, and it's recognized in the XYZ, roll, pitch, and yaw, especially the tip. So it has the characteristics of navigation there. The fiber rag grating optical sensor uses a laser, a monochromatic sweep laser, that actually travels through the width, the length, and the reflection and refraction are picked up. And we'll talk about it in the next slide. And the airway reconstruction algorithm is also different as opposed to all the previous generations of peripheral navigation platforms. Used the Vida diagnostic platform, which recognized a tubular structure from point A to point B, and really couldn't differentiate between a vessel and an airway. And as you go down into the periphery, if there is mucus plugging or compression in the lower lung zones, the system did not recognize that and just jumped on to the next tubular structure, which could be a blood vessel. So for those of you who have done superdimension will know that when you do the flyby towards the target, you can see these, the system flies through a empty space and you can see tubular structures all around you. And that's kind of the Vita diagnostic platform. Whereas in the ion robotic system, the ground truth was made by about 250 CT scans of patients that the engineers drew the airway painstakingly through the end, and then subsequent iteration of software, more data points were added, more information was added onto the ground truth, and the airway recognition is based on artificial intelligence and machine learning. So the fiber grading sensor picks up the light that goes through the sensor, and it measures twist, bend, and compression elongation. Now, this was originally designed to check the integrity of catheters, and it was actually not an Intuitive product. It was a product of Luna Medical, which was acquired by Intuitive and then superimposed on this, the system that they were already working on. And that's basically how the ion system came to existence, by losing the electromagnetism and acquiring this new technology, which actually is, for the reasons that I just mentioned, is likely to be more accurate, conceptually speaking. And the catheter tip was 3.5 millimeters. Again, having a larger catheter versus a smaller catheter, I think the airway to nodule relationship and the distortion due to instrumentation in a catheter is much more with this. So here's the cartoon of the electromagnetism-based system versus the tip tracking, and you can versus the shape sensing technology. In the bottom cartoon, you can see the FBG sensor with the central laser bundle that picks up refraction, and the peripheral 6 bundles picks up the reflection, and they measure twist, bend, rotation, and distortion. And you can see in the top portion with the green arrow, the light that is going through the catheter and reflected back are both picked up by the detector, and that's how the system tells you is able to understand and stabilize the shape of the airway that is leading to the target. So as you can tell, that you can use the system in 3 different ways. You can completely use the airway tree and the shape sensing technology by using the lock to path mechanisms and just reach the airway regardless of where the green dot is. Or you can use the tip tracking towards the lesion with a navigation platform, and knowing your airway anatomy, you can reach that, or you can use a combination of both. And that actually is a significant advantage as to how you can use the system. And this catheter stress is also, you're able to assess this. If you see this target, there is something called a tip bend radius, which is really a misnomer, and it's not measuring the bend radius of the tip. If you look at the middle panel, it's called the subway view. It tells you where there is bend. And if it basically measures the radius of the curvature on the catheter, and if it is less than 20, it actually changes color. And if it is at the tip, now sometimes the catheter has to make that bend to reach the target, because that's the way the airway is built, the conduit airway is built going towards the target airway. But the system also measures, if you look at the right top corner, there is the catheter stress is measured. If there is excessive stress with the tip bend radius of less than 20, the system is actually telling you that you're causing too much airway to nodule relationship change, and therefore you can retract the catheter and re-navigate and get a better acquisition. So the system gives you better feedback of the 2 big problems that are persistent, the CT to body divergence and the airway to nodule relationship. It gives you enough feedback so you can actually change things around and get better acquisition. So this is our study. We did a non-industry sponsored study. The company did not have access to our protocol or did not review the manuscript. We published it, and like everybody else, the manufacturer of the device got access to our article, and we were able to demonstrate an overall diagnostic accuracy of 86%. We can discuss in detail. For lack of time, I'm going to not do that at this time. But diagnostic accuracy versus diagnostic yield are 2 different things. What we expect from the system is diagnostic accuracy, diagnostic yield is up to us because there are so many other factors, the tools that you use, the way you push the tissue out, this friability of the tissue, the ability of your cytopathologist to read the slides, the sample, the way you collect the samples, you collect it in saline versus cytolite versus formalin, what is fixed and what is not fixed. All of those things play a role in the diagnostic yield. So diagnostic accuracy is what we expect from the device. Diagnostic yield is on us. So this is about the cone beam use. I'll quickly compare the two systems in the two studies that were published. They're very comparable studies in terms of the number of targets. Our nodule size was a little bit smaller with the ion system. More than half our patients did not have a bronchus sign, which I don't think is any longer needed to decide whether we biopsy these lesions or not. We did include multiple and bilateral lesions. We did include ground glass, and we had good diagnostic yield on that as well. We were able to reach 100% of our targets, and we used cone beam CT as a secondary confirmation system, which is, in a way, the way we used it is comparable to that of a radial probe EVIS, because we only used it to verify tool and lesion, and we did not have to re-navigate a single case. We were in the same airway. We did only directional change in 15% of cases, 9 patients to be precise, 9 nodules to be precise, and there was only directional changes. And the directional changes, we did not re-spin the cone beam to verify that the tool and lesion after the change, and the directional change was based on the cartoon that is provided by the ion system and not re-spin with the CT. So before I finish, I just want to play this video. This is my last slide of how our program supports innovation. I think as a program director of a interventional pulmonary program, our program is first in the West Coast. We think a little bit differently. While many programs focus on how to get the fellows to do 100 rigid bronchs, while that is very, very important, we actually place a strong emphasis on device development innovation. We have the conventional clinical trials. We have multiple clinical trials, but we also focus on innovation. And this video will show you the opportunity that we provide our fellows and how we foster innovation and provide mentorship and support.
I'm Dr. Zach Edmonds. I help run hospital medicine here at El Camino Health. As far as my work with Fogarty goes, I'm fortunate enough to be on the senior staff here, really bringing the clinical perspective to the teams and individuals here working on their innovation. We started in 2007, and in that time, we've had over 25 companies come through, several of which have developed products that are in use today and helping patients and their families worldwide. So we welcome all of the fellows who are coming through the program with Dr. Krishna to come to us with their innovative ideas and technologies to work on them. There are a number of incubation programs. I think the most relevant is our Invention Accelerator program. That's a program geared for physicians and other healthcare workers who are here on campus at El Camino Hospital, who may have ideas about ways to solve problems in their clinical practice, and may have no more than an idea or even a sketch on a piece of paper or a napkin. We will come alongside them, help them prototype and develop their idea, and ultimately planning a strategy for clinical development, regulatory clearance to FDA, as well as how to build a fundable business around the idea. But Fogarty takes no ownership in any intellectual property that comes out of the program, and there's no fee to the physician or healthcare provider in order to take part. We're very, very happy to partner with any innovative clinicians and providers here on campus.
So I conclude my talk here, and I'll take a moment to recognize one of my former fellows, Hasnain Bawadam, who introduced me here. So Hasnain has a strong interest in device development. I will proudly say that he's a holder of 2 patents, and one of which is jointly with me and the other one by himself. So we are a program that not only wants to train interventional pulmonologists to perform these procedures well, but also we strongly encourage and foster innovation. With that, thank you for your attention. Sorry I went a little bit over time, and I'm happy to answer any questions.
Thank you, Dr. Krishna. That was an excellent talk, and most would agree here that a talk of this detail, with, comparing in the evolution of most peripheral systems, if not all, would require a detailed understanding of the basic sciences and the mechanics, and none other than Dr. Krishna would be able to give that talk. So thank you once again, very well received. I have a few comments and questions here. There's a comment actually from someone in the audience who said it was an excellent talk, comparing many of the platforms. And another comment here saying, excellent talk, Dr. Krishna. I have a question here. How do we decide which system is the best for us to invest with our hospital system? I think it's a fair question with so many robotic platforms available out there.
Yeah, so, well, thank you for that question. Are you able to share who is asking this question, or is that going to be anonymous?
I don't have the name. Okay,
that's fine. Well, I'm not here to promote one system or the other. Having said that, I think the system that works best for you is the system that suits your thoracic oncology needs. What are you hoping to achieve? You know, are you interested in being a diagnostician, or you're thinking forward and want to be part of any therapeutic? Which system offers that stability? Which system offers that precision? Which system offers consistent results? Which system is easy to use and with multiple operators? Those are the factors. What is the cost of the system? What secondary confirmation strategies are you going to be using? Those are all the factors will determine what best system to use. And again, appropriate training for every procedure is important. And obviously, there are many people, experienced people in various systems in this country that can be helpful. I mean, this is a small field. There are a few of us in this country, and we are all here to help each other grow. So there are excellent support systems throughout, and that's what you should be looking for.
Thank you. I see a couple of hands up. If you guys have questions, please type them in the chat box. I have one more question here saying you showed an 84% accuracy with your paper. Is there more chances of higher yield with newer platforms?
Well, so we talked about diagnostic accuracy and diagnostic yield. Those are two different things. So we were able to, so our diagnostic yield was about 87%, 84% for malignancies. But I think the diagnostic yield is a tricky situation. Diagnostic yield depends on what tools you use, how good your pathologists are. Do you have a chest cytopathologist? How well you process the sample. Cancer cells are very fragile. If you actually pump them hard through a small caliber needle, you will lyse all the cells, and you may not see anything in the sample. You know that you are in the lesion, you're confident, but then the needle is in the nodule, but the nodule is not in the needle. And so there are many factors that play a role in how the diagnostic yield happens. So I would encourage you to put a lot of thought into how you're processing the sample. Talk to your pathologist, talk to the cytotechnologist, and talk to your team, the people who are assisting you, how to process the sample, how to handle the tools and get the sample out. That will increase your diagnostic yield. And obviously, the system plays a role in terms of accuracy. You want to choose a system that gives you a good accuracy. And the more you do it, the better you become. You don't want to be that person that is doing 10 cases every 4 years. That you're never going to be good. So the more we do it, the better we become. And paying attention to all these minutiae it will increase your diagnostic yield for sure.
Thank you. Just a few more comments saying excellent presentation. Thank you for the talk. No more questions yet. So thank you, Dr. Krishna.
Thank you. Have a nice evening.
Thank you, everybody. Thank you, audience, for joining us this evening. Thank you, Emily, for hosting this.